Hello, everyone. Welcome to the Peoria Riverfront Museum. Thank you so much for being here tonight. My name is Renee Kerrigan. I'm the Vice President of Programs and Planetarium Director here, and I am so happy that you all turned up tonight to hear what is the future of medicine from some of our leading medical minds in Peoria. I'd just like to thank our museum members and Visionary Society members who are here tonight. Your support makes this sort of programming possible, and we are always grateful. I'd also like to recommend, if you haven't had a chance to see our two fantastic exhibitions that we have in our changing galleries right now, you don't want to miss them. You have another month or so, but we have this program tonight is in conjunction with our exhibition, 10 Medical Inventions That Changed the World. It's all about all sorts of medical inventions, and then you, the guests, get to help us choose what are some of the most important medical inventions that changed the world. So you don't want to miss that. We also have a fantastic exhibition of a true American art form, the duck decoy, of which Peoria area is world-renowned for our duck decoy carvers and collectors. So those two exhibitions, don't miss them. I also thought I'd take a moment to recommend, if you enjoy yourself tonight, we have all sorts of programming here at the museum, and you can learn about it on our museum website and on our social media. And coming up just next weekend, we have a film here in the Giant Screen Theater I think maybe you might enjoy, which is They Shall Not Grow Old, colorized footage from World War I. It shows you the scenes in a whole new light. But without further ado, I'd like to welcome for a few remarks the museum's president and CEO, John Morris.
Thank you, Renee. What is the future of medicine? In all the world, you're going to hear it tonight. Here at the Peoria Riverfront Museum, the only museum of art, science, history, and achievement in America. The only multidisciplinary museum. Thanks to everyone who came out tonight to see what I regard as an absolute world-class panel of physicians to look at the future of medicine. Are we ready for this? I'm ready to hear so many exciting things going on right here in our community, and so much of a vision that extends around the country and around the world. I want to say on behalf of our board of directors and our staff who work hard to bring our community great exhibitions and great forums like this one tonight, we welcome you. We have with us tonight a number of our trustees, and I'll just introduce them quickly. Steve Jackson, a member of our board. Todd Baker, a member of our board. Dr. Tim Cundiff is here tonight, and Karen Jensen from our board. And moderating the panel tonight, a member of our board, Dr. Sarah Zallek, a neurologist with OSF and the president of the OSF Medical staff is with us as well. So on behalf of our board, I welcome you. I want to quickly say, and Dr. Zallek will introduce our panel, what an extraordinary lineup that we have tonight, and all of them friends to this museum and to the cause of inspiring others, which is the cause of this museum. Dr. Keith Knepp, Dr. Pat Elwood, Dr. Jim McGee, Dr. Rick Pearl, Dr. Matt Bramlet, and via video, Dr. John Vozenilek, otherwise known as Voz, will be with us by video. There is not a better powerhouse lineup of futurist thinkers and practitioners that we could possibly have imagined. We will be live streaming this tonight. We'll have time for questions and answers. But please help me welcome now the moderator of the Powerhouse Future of Medicine panel, a member of the board, a neurologist, and my friend, Dr. Sarah Zallek.
I always feel more important when John talks about me, so thanks, John. Thanks for having me here, Renee. It's an honor to be part of this museum, be on the board of trustees, and I learn more every day when I come here. And it's fun to be your moderator for the panel of some really visionary people. And I'm going to introduce them, but first I'm going to give you a couple of thoughts. We're talking about the future of medicine, what innovations will shape the future of medicine. from my point of view, I'm a neurologist, I'm a sleep specialist, and have some administrative responsibilities at OSF. And I think we all know that the delivery of medicine is going to change. There's a lot that's going to change in the time that we all experience medicine. And doctors used to be doctors. It used to be that a doctor knew how to be a doctor, knew everything in medicine, and could do most of the things. And then we started to specialize. And now information comes so fast. We're learning so much information in medicine that the delivery of care is going to have to change dramatically from one doctor knowing and doing everything to a whole lot of people, not just doctors, doing providing the care of medicine. So healthcare systems are going to have to innovate as much as healthcare technology. So who provides the care? It's not going to be all doctors, and it's not going to just be one doctor doing everything. Where is it delivered? Who decides what care? Patients. We are going to decide what care, not a doctor, for many of the things we do. So healthcare is changing, not just the technology. And technology has changed, the delivery of the technology that we have in medicine has evolved tremendously. I think back when I was a college student in Santa Barbara, California, and observed in the emergency room, had no medical experience, had been to the doctor for a cold, or never been sick, didn't know anything about medicine, spent a day in the emergency department, and a woman came in 1985, paralyzed on one side and unable to talk. And I said to the attending physician, "What's happening to her?" And he looked over from eating a sandwich at the desk and he said, "Oh, she's having a stroke." And I said, "Well, can't you do something?" And he said, "Nope." And he went back to eating his sandwich. And she, I'm sure, got admitted, went to rehab, and I don't even know if she survived. Now, I'll tell you, I'm going to read a text from my mom, Sylvia Nath, who's here. She sent me a text the other day, and she said, "Bill's sister-in-law Sharon had a big stroke today, had clotbuster, going home tomorrow. Yay!" So this person that I saw in 1985 now would get to the emergency department right away, because we know that stroke is an emergency, and then get a clotbuster drug that we deliver 24/7 within minutes of getting to the emergency department. And Sharon watched the whole thing because her doctor was a telemedicine physician on a screen from someplace else, because you can't have a neurologist everywhere. So stroke in my field has evolved dramatically. You're going to hear from these guys about what else is evolving in medicine. There are a number of people in the room who were born before the era of antibiotics. Penicillin was developed in about 1942 here in Peoria, right? Changed medicine. A guru in his own hometown is just a guy, somebody once told me. I'm going to introduce you to gurus. So when you think medicine is changing elsewhere, that people are developing great things in medicine and great technology, right here, you're going to hear from people who are doing this, which is really cool. Allow me to introduce our panelists. Dr. Keith Knepp I'm going to go right down the line here. So Dr. Knepp, I'm going to introduce them all, and I'll pass the microphone, and everybody will be able to give their piece on innovation in medicine. But Keith graduated from Illinois State University, went to medical school and family medicine residency here at the University of Illinois College of Medicine here in Peoria. Practiced in Eureka for a few years from 2000 to 2007, and then joined the family medicine residency program at Methodist, and then has been in leadership at Methodist as chief medical informatics officer, chief operating officer, and now is the incoming CEO of UnityPoint Health, Central Illinois. He's a healthcare system leader. Dr. Pat Elwood, many of you know Pat, but for those of you who don't, and even some of you who know him probably don't know these things about him. Pat was born in Peoria, attended Bradley for undergrad, and then went to the University of Illinois College of Medicine for medical school, did surgical training at Minneapolis General Hospital and the University of Illinois, and then trained in neurosurgery under Eric Oldberg at the Illinois Neuropsychiatric Institute, He returned to Peoria after all that in 1961. And then he was foundational in developing medical education and neurosurgery in Peoria. He participated in the design of the University of Illinois College of Medicine medical school here. He was the founding professor of neurosurgery at the school. He was the founding CEO of the OSF HealthCare Illinois Neurological Institute, and really led us in as what we do in neurosciences here to develop neurosciences in Peoria. Most recently was the research director at the INI, OSF Illinois Neurological Institute, has developed extensive clinical facilities And he shows up for grand rounds every Friday unless he's in the south of France or doing something a little bit more interesting than that. He's written a book recently called A Life in Neurosurgery. Did I get the title right, Pat? Yeah. So if you'd like a good read on A Life in Neurosurgery, it is available. I'm sure he'll sign your copy. Pat Elwood truly is a visionary. Not just in medicine, he's a visionary. He also has a superhuman capacity for knowledge acquisition. So if anybody was going to practice all of medicine, it might be Pat Elwood, but even Pat probably can't quite do everything we need to know, which is why we need to innovate the delivery of medicine. Dr. Jim McGee, sitting next to Pat, is a radiation oncologist at OSF. He went to medical school at Loyola and then did residency in radiation oncology, therapeutic radiation at Northwestern. He's the chair of the cancer committee at OSF HealthCare and at St. Francis Medical Center here in Peoria. He maintains his affiliated professorship of radiation oncology at Loyola, and he's published a number of papers. He's also an interesting guy. He's got a very broad set of interests, including that he's a member of the National Council of the Juilliard School of Music in New York. And he's also the founder of the Spirit of Hope program for public education about radiation oncology and cancer control in collaboration with OSF HealthCare, St. Francis Foundation. So he's a clinical and community force, I would say. Dr. Rick Pearl, what can I say about Dr. Rick Pearl? My friend is also an interesting and storied person. I had to cut out a lot of things that are written about Rick because he's done a lot of things, including that he's an Army career commercial helicopter and airplane pilot, certified flight instructor. Then he decided medicine would be a good idea. So he got his medical degree at Wright State and surgical residency in the Harvard Surgical Service at New England Deaconess Hospital, pediatric surgery. So he's really a pediatric surgeon. His pediatric surgery residency was in Toronto. And then he finished his Army career after 28 years as Chief of Pediatric Surgical Services at Walter Reed Army Hospital, or Army Medical Center, excuse me, and then he became Surgeon-in-Chief here at Children's Hospital of Illinois, OSF. And he is currently the Director of Surgical Simulation Surgical Simulation at Jump Simulation. You're going to hear a bit more about that. Rick is a champion. If he's got a cause, it's going to get done. So he is a force to be reckoned with. Matt Bramlet, sitting on the end, is in Rick's world at Jump, but comes to us having been an undergraduate at Greenville College in Illinois, and then Southern Illinois University for medical school, pediatric residency at University of Louisville, and then pediatric cardiology fellowship and advanced training in pediatric cardiovascular magnetic resonance, just like everybody else here did. At Bradley Hospital for Children at Indiana University. And I'm telling you all these things because otherwise these are just other doctors, right? So you need to know what these people have done and how they've trained because they've done some really cool things that will give them some framing for what they're going to talk about. He's the medical director of the congenital echocardiography, or he was echocardiography lab medical director at Children's from 2010 to 2015. He's certified in advanced pediatric cardiovascular MRI, as one might imagine with his background. He is the director of the Children's Hospital of Illinois Congenital Cardiac MRI program, and he developed, this is cool, a state-of-the-art congenital MRI program that ultimately led to a research collaborative agreement with GE Healthcare. He is the curator, this is national, of the NIH 3D Print Exchange Heart Library, the National Institutes of Health, that NIH. So Matt Bramlet is a true innovator, and it'll be very fun to see what he has to talk about today. And not with us today because he's teaching other people to do smart things in Tampa at a conference, I believe, is Dr. John Vozenilek. So we'll hear from him in a video at the end. He's a clinical professor of emergency medicine, came to Peoria after he led the simulation system center at Northwestern University. Rick Pearl found him and collaborated with him really to come here and develop JUMP. So he's the chief medical officer of the JUMP Training Simulation Education Center now, and also the Duane Mary Cullen Endowed Professor of Simulation Outcomes at the University of Illinois College of Medicine. He's a collaborator and investigator at the OSF lab at the UIC Innovation Center for Discovery Partners Institute in Chicago. And he's a man, as Sarah Rush, the dean of the medical school, says, is a man who doesn't just talk about making things happen, he makes things happen. So when he and Rick Pearl got together and made jump simulation happen, it's because they get things done. So I will now stop talking. That's all you hear from me, unless I need to understand something better, because if I don't understand what they're saying, I'm going to guess that you don't understand what they're saying, because I'm going to ask as we go along. If you look quizzical, I'll interpret. But I think this is going to be straightforward and really great stuff. So let's now hear first from Dr. Keith Knepp.
Thank you, Sarah. Good evening, everyone. I'm excited to be here tonight. I have to tell you, as I prepared for this and looked at who else was going to be on the panel, I was intimidated by the expertise that was going to be next to me. But I am proud to be the only generalist here. As you heard, I'm a family physician by background. So I thought I would lead with a little story about how we think about specialists, and particularly subspecialists. You know, a subspecialist is someone who learns more and more about less and less until they know everything about nothing.
Hey. Watch. I think I need a microphone.
Clearly that's not true of this panel. I am someone who knows just a little bit about a lot of things and not a subspecialist or an expert. So I'm going to lead off with talking about some general thoughts about where the future is going on how we approach medical care. So 3 quick slides. We'll start with how we measure. So think about how things happened today, or maybe in the past, when we wanted to get some information. We needed to have information about your health. We do so and have done so episodically and in person, collecting information one person at a time at one point in time. You come to the doctor's office, a nurse takes some history, and we measure your vital signs or draw some labs. But how do we collect information about each other right now and all the rest of our lives? It happens all the time. Google's watching where I'm at all the time and recording and putting ads in front of me, just continuous data stream. I have an Apple Watch that's constantly measuring my steps. And now we have smart clothing. That's an EKG shirt, as you can see, that could record a 12-lead EKG if we wanted it to. So, and why should we just have episodic information about our health history? Why should that not be a rolling database that gathers more and more information over time? So how we measure and collect information about our health is already changing and will continue to change. Then how do we connect? Well, I put communicate, communicator, connect. How do we interact with each other historically? It's in a room like this or in an exam room, person to person. But more and more, that's happening through teleconnections, right? So we just heard the story of a stroke treated by a neurologist across a video connection. Dr. Pearl, as we were starting here, was talking to me about surgical robots and how that was first invented by the Army so that an operator in another part of the world could perform a surgery on somebody in the combat field in a remote place. Sorry, I'll stop. But we no longer have to be in person. But even those things pale in comparison to what's really coming, which is how we evaluate. How do we make decisions? How do we process all that information and then decide what the answer is and what we're going to do about it? So I just want to tell you one story about artificial intelligence. And you've probably all heard about Deep Blue, I think was the name of the IBM program that finally beat the world's expert in chess. The real story about games and artificial intelligence, though, came in 2016 and in the last couple of years with Google's DeepMind project. And they created a program called Alphago. And Alphago was programmed to play the game Go. The game Go is a board game, which is exponentially more complex than chess. So it's really hard to program a computer to play Go, but they did so. And by the time they were done, it was able to beat the world's best player in Go 3 out of 4 matches. And the person resigned in the last one, so the computer won 4-1. What's even more impressive than that, though, is that was the first generation. That computer was taught how to play the game by humans. The next version of Alphago, which they called Alphago Zero, taught itself how to play the game. It created a neural network, and They had the computer play games against a version of itself. It played millions of games, and within 24 hours, it was better than the other computer and better than anybody in the world, and remains so to this day because it taught itself. And what was interesting about that is the moves that the computer used in the game were moves that had never been seen before. The strategies were different because it had learned new techniques. That kind of artificial intelligence is something that we don't even understand, really. You know, we think we program it, but it's taught itself. So now think about, we've collected the information, we've connected perhaps remotely, and now we're using a neural network, a non-human brain essentially, to help us find the right answer. So different people are reflecting differently on what that means. The author of the book Sapiens, Yuval Harari, talks about a future of superhumans that are genetically engineered and working with artificial intelligence, says we're going to be run by algorithms, and predicts that major change is coming. But there's another book written by Siddhartha Mukherjee, who wrote The Emperor of All Maladies about cancer. He wrote this little book that just came out called The Laws of Medicine. And in that, he tells stories of complexity of human experts who are taking the pieces of knowledge they have to solve real-world problems. And he says, we will not be replaced by algorithms. So I don't know the answer to that, but it's intriguing, and we know change is coming. So with that, I'll tee things up for the real experts here to tell you about what they're working on.
Thank you. I'll go on from there, actually.
Hold on a little closer so you can. I've been dying to tell Pat.
I've been dying to tell Pat Elwood what to do for a while, so I just told him to hold the mic closer, so I'm feeling, in charge.
Oh, that's wrong.
David, do we have some tech support here?
I can't get to the slide I want.
Trust the innovation, however.
I'll start. Years ago, I operated on brain tumors
Get a little closer to the mic.
after performing the tests that were available at the time, ear studies and pictures of the blood vessels in the brain. And they told me generally where the tumor was located, which side, front or back, which lobe, but not very precisely. And then I took the patient to the operating room, turned down the skull, opened the covering of the brain, and I was confronted with a picture like this. The brain looks absolutely normal. And I know that 2 or 3 millimeters under that normal appearing brain, there's a tumor buried there, but I don't really know where to make the incision. And usually I made the right incision, but sometimes I made the wrong one, and sometimes there was some loss of brain that could have been spared. Advanced several decades to the current era.
You want to push it's down, backwards from what you think.
Yeah. And with CT and MR, we're making beautiful pictures of the brain and all of the trouble in the brain. And each year we get more information. We now can see not only the speech areas and the motor areas, and then with the fusion tensor imaging, we see the pathways that connect the various areas in the brain, so that we can then make a pathway right to where we want to go with the tumor. Just like this. Our instruments have infrared emitting diodes on them, and then with the computer optical direction system, essentially we can GPS our way down to the tumor, avoiding any critical areas, just like you use Google Maps when you're in a strange city. It's really made, it's in the process of making major intracranial surgery much more safe. Being lost in the brain is essentially gone forever. And each year, there are new developments. We can now put microelectrodes in very tiny targets in the thalamus for deep brain stimulation for Parkinson's disease. We can thread a very fine laser fiber into a seizure focus in the brain and obliterate the seizure focus for the surgical treatment of epilepsy without opening a big craniotomy flap as we did in the past. This general approach, that is imaging with guidance systems, is applicable to areas all over the body, not just neurosurgery. I think perhaps, at least in my mind, it has its greatest value in brain surgery, but deep in the brain, but it has very wide application. The second major development that I'm excited about is the genetic characterization of disease. It now allows us to separate illnesses that seem to be all the same into very discrete groups that have immensely different treatment and immensely different behavior, even though they seem to be the same thing. And as a result, we're doing a much more accurate selection of the treatment, whether it's chemotherapy or surgery or radiation or immunotherapy. At any rate, it's more selection of the treatment is more accurate. In brain tumors that used to look to me the same under microscopy, with identifying the genetic deletion, for example, in a oligodendroglioma with a 1p19q co-deletion has a much better response to chemotherapy than those that do not have the deletion. So the practical result is precision therapy. We're not quite as far along in the next natural extension of that is actual targeting the gene defect in the therapy. But there is a lot of exciting work happening in that area. With CRISPR gene editing, I think we're just tantalizingly close to managing Duchenne muscular dystrophy. There are a lot of other illnesses that have a single gene defect where there's active work on solving that problem. And diseases like cystic fibrosis, for example, that have an identified single defect. The introduction of new DNA to address these diseases is really rapidly turning into the realm of big business. Pfizer, for example, just paid 560 million euros for a piece of a French company that is getting close to having gene therapy for Wilson's disease, which is a complex copper metabolism disease that affects the liver, but has its major clinical manifestation is a bad tremor, rigidity, and dystonic movements, sort of like Parkinson's, only much worse. So I think big science and big business bring hope for specific gene therapy in the management of a number of inherited diseases yet to be solved, and it's going to be a really big social problem, is how can we afford these dramatic but impossibly expensive cures. And the third innovation that I would like to mention is following up on what he's talked about. And I think it's the most exciting for its potential for disruptive change in virtually every aspect of medicine. And that's the application of artificial intelligence, machine learning, and natural language processing to clinical medicine and research.
I'm gonna press down.
Oh, I've got it backwards. Yeah. The New York Times had, on March 11th, just a few days ago, they described a program in Madura, India, that Google and its sister alphabet company, Verily Life Sciences, are using artificial intelligence to scan fundus photography in diabetics to detect diabetic retinopathy. This is a picture of a diabetic with diabetic retinopathy. There are hemorrhages and little microaneurysms and edema. And it's a serious thing that causes blindness in diabetics. This artificial intelligence program allows screening of diabetics and gives an answer in a minute or less, and does not require an ophthalmologist. So it clearly has, in populations like India, it has remarkable potential. The same company is working on a similar paradigm for screening for macular degeneration. These neural networks, as Keith mentioned, allow the integration of large data sets of the clinical problem the patient has, their images, pathologic data, and then the neural networks can train algorithms that become progressively better based on the large experience. It's really kind of like a clinician who has seen 1,000 cases is better than a clinician who has seen 5 cases. Only now, with artificial intelligence, they're able to put together just massive amounts of data. I think initially, most of the applications in medicine apply to those things that involve pattern recognition, radiology, pathology, dermatology, and to a lesser extent, ophthalmology, because the technology allows them to look at recognition of these patterns that are well recognized by these clinicians and make diagnoses. There's a lot of hype, lots of talk that we'll no longer need radiologists or pathologists or dermatologists. But I believe the truth is sort of analogous to the role of a robot in an automobile factory. I think AI is going to assist in many, sometimes complex, repetitive tasks, and the clinician will have time then for tasks that require great judgment and cognition, and hopefully even have time to advise other clinicians and meet with patients. Integrated with the electronic medical record system, I think it's going to have the potential to assist clinicians in considering the span of diagnoses and perhaps select the optimum test to be done. For example, I'm constantly troubled by clinicians doing a CT scan when an MRI is a better test in a particular situation to diagnose a brain problem. I think with AI coupled with an electronic medical record system, we will make progress in that regard. AI, artificial intelligence combined with genomic sequencing gives us the ability to identify rare genetic diseases that are probably beyond the ability of a single clinician. There's a rather dramatic example in the Bay Area last month where an infant with uncontrolled seizures was discovered to have a very rare metabolic problem and could be changed and treated very effectively with changes in dietary intake. So I think AI is going to change medicine in almost everything we do, from radiology to actual clinical encounters to pharmacologic research. As every, as in every development, there's a danger of hype and wrong decisions and disappointment, but I think there's a comparable danger that there is a lack of sense of urgency about this opportunity. I'm struck in reviewing the literature that so many of the papers lack involvement of the appropriate clinicians. They're frequently written by informational computer scientists. And this is an area where teams of AI science and clinicians are critical. And it requires the time commitment of physicians and clinicians. And quite frankly, if clinicians aren't doing direct patient care, it's kind of hard to get their attention. So that's a worry to me. I think we probably need a change in the way we do medical school and the way we do postgraduate residencies to end up with the kind of manpower we need to capitalize on what I think is probably the most exciting thing in medicine. Thank you.
Thank you, Pat. I'm going to take advantage. Well, first of all, the more doctors you have on a panel, the more likely one of them's going to get called. So welcome back, Jim. What you talked about, and you said a lot of things, but a couple things I think are worth commenting on. How many of you ever been to the doctor and left because not knowing exactly what the plan was or how you were going to follow through on that, or what your doctor was talking about because the doctor was in a hurry? Have you ever been to the doctor and had that happen? If we have AI doing some of the diagnostic stuff and some of the stuff that takes a lot of time, and you can tee up the information so that the doctor has more time to have a conversation with you and plan and think and do, that's one of the real endpoint values of AI. The other thing that you mentioned was big science and big business. And there's a lack of urgency, partly because academic medicine has done a lot of things to solve questions in medical science, but not necessarily apply them as fast as possible. And now, a lot of medical innovation, I think, is not just in the academic world, but really happening in partnership with business or being driven by commercial interests, which has upsides and downsides. But one of the upsides is urgency. So if you're developing something and you're going to market it, and if it's in collaboration with an academic organization, it's maybe more urgent to get done. So there's clinical urgency, but there's also an urgency of who's doing the work and going to lay it out. And I think that that's one of the changes in what's happening with medical innovation. Do you agree?
You know, yeah, I really feel like,
Do you want to pass the mic back to Pat?
I feel like they will overcome the innate conservatism of physicians. For example, the Microsoft Research Unit at Cambridge in the UK is partnering with both Princeton and Oxford Biomedica to explore the rapid development of virus vectors that are used to insert DNA in gene therapy. And if you get the power of Microsoft behind something, it's going to be kind of hard to stop it. It makes me optimistic.
Thank you for your insights, Pat. Jim McGee.
Well, we're not at the point where people can't have problems in the hospital, so we'll have to take off after this. But we'll get there someday, I guess. We just won't have hospitals, and then we'll have their problems outside the hospitals, and that'll be a lot easier then, right?
So that's innovation.
There is hospital at home being developed on the East Coast. So a little bit about cancer. Cancer control and cancer treatment affects large numbers of patients, very, very large numbers of our population. So as Pat's said, there's a lot of company coming on now with therapies that are related to the immune system and to genetics and so forth. And this was an example of a young girl with mediastinal lymphoma, a big tumor lymphoma in the center of the chest. And what we're seeing now is the ability to really image these in a way that's very specific to what the types of receptors are that tell you then what kind of immune or molecular therapies to use to put these tumors into remission. This patient had not been benefited much by chemotherapy, but had a monoclonal antibody, an immune type of the therapy, and tumor went into a very deep remission that allowed a successful transplant and cure. So getting things down to a very personal level, as Pat said, which we have thought about a lot, I think, in terms of treatment, but we really need to start thinking about it in terms of prevention. And so as we talk about cancer control, screening, and prevention, really the big thing there is in the notion that you can personalize prevention. You can, if you tell somebody eating pizza is bad for you, that's, yeah, oh, fine. But if you tell a young high school girl that if she eats pizza, her risk of breast cancer is going to be 10 times higher than if she doesn't eat pizza, but she can start eating pizza when she's 29 years of age, because by then that risk factor will have essentially passed. So when you can make things that personal, then you start to get to the key problem that's always been the case in terms of cancer control, and that's the motivation. We've had a lot of science, and we disperse that through education, and it doesn't do any good because people aren't motivated. They're not motivated because, well, I'm not the one that's going to get that polyp. I'm not the one that has that susceptibility. If you can personalize it and say, yeah, you are, then you have a better chance of motivating their behavior for the better. We're going to be able to, as Pat's shown, we're going to be able to image where these tumors are at and be more selective in treatment. This is a very primitive level at this point, but a carbon-11 PET scan, unlike a sugar PET scan, will pick up where prostate cancer is at, and then with modern methods you can decide to target the areas just where that's at. Here in this case with interstitial radiation implants with high-dose rate techniques that can be very selective, and here we're treating all the prostate. Well, we don't have to. When these imaging methods are better, we'll select and just treat the abnormality, and then the side effects will dramatically decrease. We're learning more about how cancers behave. We've learned that when a cancer spreads from the starting point to the first site of metastasis, it doesn't necessarily mean it's spread anywhere else. Sometimes we say that's stage 4, but not all 4s are 4s, and sometimes you can treat the primary site and the first metastatic site, and that be the end of the cancer. Tumors can metastasize, and then the metastasis can metastasize to the metastasis, which then metastasizes. But in many cases, if we get down to an earlier detection, we can cure a cancer even if it's had a limited amount, or what they call oligometastatic disease. And when we have oligometastatic disease, or very early types of situations, and things like radiosurgery is shown here for a lung tumor, can be highly effective in terms of just no surgery, no operation, maybe 3 radiation treatments, and 95-98% cure rates for early stage lung cancers. Again, picking it up early and treating it without much side effect. Now, something Pat and I did together for 25 years has been brain radiosurgery for metastatic disease, and that's all aimed at treating only the disease in the brain and not messing up the patient's brain function. But it's been observed in some situations that when you do brain radiosurgery, the patient's cancer elsewhere in the body goes away. Why would that be? Well, it has to do with the fact that the body's immune system can react to the antigens of the tumors that are released by doing radiosurgery on the brain. So the brain radiosurgery is really a great presenter of those antigens to the immune system so that it can react, and then it works elsewhere through the whole body. And a key principle here is that not doing whole brain radiation keeps the immune system intact. And, well, why is that? Well, when you think about treating the whole brain, it takes a few minutes to do that, a couple minutes. 90% of all the blood goes through the brain in that period of time, and so you've radiated all the immune cells that are rushing out to try to fight that cancer. So by doing radiosurgery, you're sending out that releasing factor that tells the immune system what to attack, and you're not killing the immune system and the chances of reacting to that. So radiation therapy can be very immunogenic. It can really stimulate the immune response. As long as you're not giving the patient chemotherapy, as long as you're not doing big field radiation and killing the immune system response at the same time that you're initiating it. That's this notion that radiation is not only immunogenic, but can initiate an anti-inflammatory response, which turns around and works against you. So we never realized all this stuff. We just knew that sometimes these things happen. And now we're looking at this balance of molecular things that we have to fit into in order to optimize the response to the whole menu of cancer treatment. And things like all these multi-drug chemotherapy regimens that go on forever and ever are starting to go away and be replaced by immune agents that are basically taking pills, and radiosurgery and brachytherapy and other types of radiation that are much less damaging to the patient as a whole. When you get into some of the ion therapies that are widely available around the world nowadays for limited treatments, you start to see that we have the ability for these radiations to come in and stop and not damage the whole patient. But in looking at this more carefully, the immune response that's seen and the release of these agents and so forth, and the effect of the radiation in killing cancer cells relates to what's called this relative biological effect. And in some of these particles, that relative biological effect is far greater than it is with X-ray therapy, the standard radiation therapy that's out there. And so we see with protons an effect at the end of their range of 2 to 3 times what it would be with X-rays. And with carbon ions, it can be 5 or 6 times greater. So there aren't going to be any things that are truly radio resistant anymore. It's going to be just a matter of doing the right imaging to get it all matched up for an optimal response. One of the things that's really untreatable these days in the conventional world is a sarcoma muscle tumor arising deep in the abdomen right by the spine. And in trying to do radiation to that area, you're You can't do much because it's going to damage the bowel, it's going to do damage to the kidney. This is a picture of what's called grid therapy with proton beam. Proton beam because it's coming in and stopping, it's not going all the way through into the rest of the abdomen. And grid therapy because you see there's some streaks of very high dose there. Now, on its own, those streaks of high dose would totally necrose that tissue, but by not doing it through the whole area, the patient doesn't die from that necrosis, but again, there's an intense reaction within the tumor to that stimulation, and then the body's processes work to control the whole tumor, not just the part that had the extremely intense radiation. So we're starting to see things done that look at dose and time relationships and that take into account how much killing these types of radiations will do. And so that instead of just a simple line graph, now we have to look at the three-dimensional models of how that radiation effect is taking place. And it's a dynamic that's not unilateral, it's not straight line. It's very much going in different directions. We're looking at the temporal relations as well as spatial relations, and so dose rate is coming into play. We learned early on that with gamma knife radiosurgery and treating painful facial lesions, treating nerves, that as the radiation sources got older, we had to give more dose because it wasn't having as much effect. In linear accelerator, where we're treating most cancers, the conventional mode runs about 600 rads per minute. Our fancy one that's really high speed will treat around 2,000 rads per minute. And where we're going is a little faster, treating at about 640,000 rads a minute. So that the treatment time would actually be on the order, measured not in minutes, but in terms of milliseconds. And that helps you get the patient treated faster, yes, but there's also, let's see, there's this information on high dose rate studies coming out of Paris that shows that when you treat normal tissues that rapidly, they don't have time to respond and cause fibrosis and radiation damage. So the tumor still dies, and the normal tissue doesn't know anything happened. So, lots of interesting things going on.
Thank you very much, Jim. So far, there's a localization theme here. We're going to localize healthcare to the patient, and we're going to get more precise in finding things in the body and treating them, which is fabulous. Rick, what do you have to say about medicine?
Well, I'm going to talk about two areas that I've worked in.
In 5 minutes.
Oh, yeah, thanks.
Is there, there's a reception afterwards. Renee, where are we, Renee? Do we have a reception afterwards, John? Okay, just to remind you, there's a little refreshment, so if you have to run to the bathroom, you can, but come right back. But there's going to be refreshments, so hang with us. We've just got a couple more pieces here.
I'm a pediatric surgeon, and before I came here, I was a pediatric transplant surgeon. So I'm going to talk about two areas that I worked in before I came here, and this may affect somebody in this room, somebody you know. You may know somebody's had a transplant, but the problem with organ transplantation is either someone has to die for somebody to get a transplant, or it has to be a living related transplant. So either somebody died for us to do our work, or we took an organ from somebody in the family or a close relative, and a living related transplant is the only operation you can do with the potential to have a 200% mortality. And that's, not good. So the idea with tissue engineering was, as Jay Candy said in this slide, we can't find the organs to transplant. Why can't we build them? Okay? So that's what tissue engineering is all about. So this is a slide from Jay Candy, the gentleman I just quoted, and this is his Candy ear mouse. So he was talking to the head of plastic surgery at Boston Children's about 25, 30 years ago, and he said, what's the biggest problem you have in pediatric plastic surgery? He said, I can't really make a good ear for a child who's born without an ear. So Jay took this on as an issue, and he created a protein matrix of a human ear, and to make it grow, he put it behind in the back of a mouse, and this is a picture of a created tissue-engineered ear growing in the back of a mouse. Now, this hasn't come to fruition yet, but this is the idea of tissue engineering, of growing a human organ, but this is not a human organ, but growing an organ that looks like a human ear out of engineered tissue. Now, the organs that are being worked on right now are heart, liver, lung, kidney, blood vessels, skin, cartilage, and bone. I will tell you that the blood vessels, skin, cartilage, and bone have already come to clinical work. And blood vessels in Columbus, Ohio, Chris Brewer has made tissue-engineered blood vessels that will be implanted into children. And the advantage of this is these blood vessels will grow with the children. Now, previously, kids with congenital heart disease that required operations as newborns, they would have plastic tubes put in, and these operations would have to be repeated 2 and 3 times as the children grew, because these plastic tubes don't grow. These tissue-engineered blood vessels grow with the children. The protein matrix that represented the size of the blood vessel would be implanted with bone marrow-derived stem cells from the child. And then the protein matrix would eventually go away, it would become a blood vessel, and it would just grow with the child. So these tissue-engineered blood vessels become the child's blood vessel. And these blood vessels are now being placed in children on a phase 3 clinical trial with the NIH. It's going to, in the next few years, going to be in wide application. Skin, artificial tissue-engineered skin is being used in burn centers around the country. Cartilage is being implanted to replace knee cartilage right now, and bones same way. So those 4 tissues already happening. Heart, liver, and lung, kidney will happen. Now, there's 2 ways to make these organs. The first way is that they have a scaffold that's made out of a protein kind of substance, and then it's implanted with either embryonic stem cells, adult stem cells, or stem cells from the patient, which is the best way to do it. About 72 hours or so before the implant of the organ, you get bone marrow-derived stem cells from the patients, so there's no immuno problems. And then that is then put in an incubator, and about 72 hours later, the organ is then put into the patient. But this is the most common way to do it. The other way is, now this is a decellularized young lung, which is then recellularized, and this is the lung of a recellularized rat lung. You can see how it works, it's working fine. And then this is a decellularized pig heart, which is recellularized. You'll see it beat in a second. So those are the 2 ways, scaffolds or decellularized organs, which are then recellularized. But those 2 systems are going to come to clinical work in the next decade, I would say. So organ transplantation will no longer depend on cadavers or living-related transplants. It's going to be tissue engineering. And this is going to be a game changer.
So hang on to your kidneys.
Now, the other area I'd like to talk about is Star Wars. You all remember 1983, when President Reagan funded the Star Wars initiative that was going to be this in-the-sky protective thing that was going to keep us having ICBMs blast us away. Remember that? Okay. And, well, the Army snuck a few $100 million from that initiative to develop surgical robots.
Something useful.
Something useful, yeah. And the idea was that we were going to have surgical robots be used in combat. And instead of surgeons like me, say, there
are no surgeons like you.
So I commanded a 4 surgical team. I was deputy commander of the Combat Support Hospital in Desert Storm in 1981. This is a picture of one of our surgical vans, and that little thing on wheels is actually an operating room. Okay?
Oh my goodness.
And then here's the operating room opened up. That's it.
Oh my goodness.
So the idea of these robots was we're going to have, instead of having surgeons plopped all over the theater at wartime, doing an operation here and an operation there, we were going to have these surgical vans out there with the robots, and we'd have technicians put the patient on the table, mount the robot. I'd sit back at Walter Reed, and I'd be operating. And I could operate on a patient in this band, next time I operate in that band, next time I operate in this band, and we could extend the use of the surgeons all over the combat theater. What a great idea. And it still is a good idea, by the way. Now, what ended up happening? Well, it didn't get developed fast enough for Desert Storm, obviously. But I'll tell you, since the robot was developed, just as kind of a gee whiz bang thing, a surgeon in New York City operated on a patient in Paris and took out a gallbladder. So it's doable, okay? So what's the real utility of this? Well, let's take a look at really rare operations that are done infrequently, and only a couple of people around the world do it great, right? So some surgeon at Sloan Kettering, New York City, could collaborate with a surgeon in Paris, and an operative team in Paris would put the patient on the table, do the pre-op work, dock the robot, do the basics of the operation, and when the really complex part was needed, the surgeon in New York City would take over, do the complex part of the operation, and then the surgeons in Paris would finish it up. Okay? That's completely doable right now. Okay? And think about the extension of great surgery worldwide for just very complicated things, not done frequently, but done great. Okay? That's the real utility of something like this. All right? And I think that's just something that could happen one day. But anyhow, we're out in the desert instead, so the surgical robot. So the Army made the robot, and we made intuitive surgery billions and billions of dollars. There you go.
See, it was a localization talk about taking the care to the patient. It's perfect. Thank you, Rick. Now, Bramlet.
So I'll try to run through this pretty quick here. But in my field of pediatric cardiology, we deal with patients that are born with hearts that are completely mixed up. So a baby that's born with a congenital heart defect may in some instances only have 2 chambers of their 4-chamber heart. So you can imagine between a normal 4-chambered heart and all of the different variations that can occur, you can have all kinds of different 3D problems that are actually related to that. And at JUMP, back in 2013 and 14, we started printing on a 3D printer the heart. Here's an example of a 3D printed heart that we printed for one of the patients. And so you can imagine what's occurring is whenever the surgeon is getting ready to go operate on this complex 3-dimensional puzzle, the fact that they can hold that heart in their hand before they go into the operating room improves their understanding, improves all of our understanding around this complex 3D problem. And so it just so happens that my field of pediatric cardiology is really the perfect substrate for the idea of translating, instead of looking at x-rays, instead of looking at CAT scans, MRIs, we're actually looking at these hearts by interacting with these hearts. And so the purpose of 3D modeling, as we envision it at JUMP, is this idea of practicing on this single patient before you go into the OR. So that's at the highest level of simulation. In some fields of surgery, there may be just a handful of surgeons that operate on a very specific case, maybe 80 times a year for the past 20 years. You may consider those handful of surgeons the experts, yet the number of patients that have that disease far exceed their capability on just how many patients that they can see. By printing out a 3D printed version of that patient's specific heart so they can actually interact with it and observe the night before surgery, we're creating experts on a singular patient. And that's at the core of what's occurring with 3D modeling. And so at JUMP, we have this process. We're actually doing this since 2014. There hasn't been a complex congenital heart that we've not done this process on. So we've either printed it in 3D form or we've put it into a virtual form of 3 dimensions, which is virtual reality. And so in order to get this, you have to actually order a scan, CT or MRI, that's going to get you the 3D information, you have to segment it. And it's important to understand what segmentation is. What you'll see on the screen here is a CT scan in 3 different planes. So X, Y, and Z represented. And in that light green color, the engineers, myself, we go through and slice by slice, we convert that heart into what I see. So the radiologist knows those little intricate pieces of that scan. What we're doing is we're capturing that expertise, and we want AI to do this eventually, but it is so complex, it still requires a great deal of understanding. And so what we're creating from this CT scan, where the 3D information lies, we're actually creating that 3D heart that you can kind of see there in the bottom right-hand corner. And so once we started doing this, the idea was how can we move forward in advancing this into how we walk through. So once it's segmented, we want to make sure that it's an accurate representation of that patient heart. And then we move into virtual reality. How can I now understand the same information in virtual form so I'm not having to actually 3D print? And so this is so hard to describe 3 dimensions in any 2D format, even this big, large, huge screen we have here. And so this is overlaying what I can see in VR on the screen.
So you can walk through organs with this system. It's super
You can
cool.
walk into the heart. Yeah.
Right, it's you,
Yes.
I've done this as a, observer of this cool thing. You can walk through parts of the body and figure out, if you're the surgeon, imagine getting to walk through the heart that you're going to operate on. It's amazing.
So what is at the core of this value? Like the main question we ask ourselves is, why do we do something? And what we're doing is we're improving our understanding around complex problems. Now, as we improve that understanding, what is education? What is this communication? If I understand it better, then can I have my team understand it better? Can I have the med students, the residents, the patients understand it better? And that's where we expanded beyond just let me interact with this heart so I understand it better. Let me create a scenario where I can now communicate that understanding better. If I were to take a bunch of 2D pictures of any object and display them in here and have everyone try to draw what the 3D object was, literature proves that we're all going to get it a little different. That's what we're eliminating. We're eliminating the visual spatial skill disparity amongst whoever we're trying to communicate around these complex 3D problems. And so this is a virtual reality version. What I'm doing is I'm teaching Brent how to image a pulmonary valve. However, what you'll notice is I'm not standing there anymore. And what is recorded, I'm able to record that understanding in a virtual space. And then the learner, the patient, the student, the surgeon, whoever it is, can pause me, which you'll see he now paused me, and now he can interact with that same information in 3 dimensions. And so that is at the core of what we're doing is how can we capture this information and push it forward to a whole team. And so at JUMP, we can go for congenital heart disease from a CT or MRI to the surgeon or treatment team reviewing it in virtual reality in an hour and a half. And around the nation, this is about as fast as you're going to find anywhere. And so I've got just a couple examples here that I'm going to fly through. This enables us to take traditional medical images. Here you see an ultrasound. How I'm able to overlay it exactly on this 3D model of this heart to combine our understanding from traditional medical images with the 3 dimensions. And again, this is a 2D video of this rather than actually getting in and see it. And the way our surgeons, the treatment team are viewing this is actually in the virtual reality. From here, here's an example of a case with, this patient has a couple of stents in the pulmonary artery, and I have a fluoroscopic image there, and you can see how this information is in 3D, and the surgeon can review this, the interventionalist can review this information before they go into the cath lab. Here's an example of something that's super complex. I've got those arrows all pointed at the way the blood is getting back to the heart, which, trust me, is super confusing. And so to be able to review it in this manner, I mean, what's occurring right here is how our surgeon will actually review this case before he goes into the OR. I have on the screen, it's real busy, but there are all of these different ways that are the top of the line medical imaging viewers that exist today, but it's not until we actually take and create that 3D model that we actually gain the value of this particular case. I'd say there's a very specific style of congenital heart defect where the vessels all go to the lung in a different way. The surgeons are able to actually go into VR and understand and see how all of those connections are connected in the unique way so that they can plan it out in their head. And I know I've got several surgeons up here, but the reality is sometimes you hear, I'll figure it out when I get in there. We're trying to figure it out before we get in there.
Rick just said this is better.
Thank you. Yeah.
So, you know, the thing that JUMP really affords here in Peoria is, it wasn't really highlighted, but there's a huge research endowment that combines the University of Illinois College of Engineering with the clinicians here in Peoria. And it's only by bringing the engineering expertise and pairing it up with the clinical problems that we're able to get to the point where we can understand and move this forward. And I would say that that's a tremendous resource that is just, it's an amazing resource that's here locally in Peoria.
Let me say something about this briefly. 20-year-old parents of a child with congenital heart disease, and the surgeons trying to explain to them the problem. It's hard enough to explain what a normal heart is like. Now you're trying to explain to them this complicated heart and what's wrong, and as you're talking to them, they've got a 1,000-mile stare, right? But now you have this printed heart that you can hand to them and say, this is your baby's heart. And we cut it open in slices, and you can open it up, and you can show them inside. Now here's the hole that goes from the right ventricle to the left, and here's the problem with this and that, and here's what we have to fix. And you see this aha moment, because they get it. They can see what's wrong. It's three-dimensional. It's their baby's heart, and they can see visually exactly what's wrong. This has been like a complete game changer in trying to explain to families what's wrong with their baby's heart. And from my point of view, over and above all the other things that Matt just showed, the value of just that has been like extraordinary.
So Matt Bramlet is leading this work. Thank you. It's fun to see that stuff. It's also fun to have Dr. Bill Albers here, who really built the foundations of congenital heart pediatric cardiology. Where are you, Bill? I saw you somewhere nearby. So thank you, Bill, for your foundational work as a visionary 40 years ago. And the guru in your own hometown is just a guy is the perfect description for Matt Bramlet and for JUMP. Really, what we're doing here at JUMP, we were at a JUMP event a year or two ago, and one of the audience said, "Is pairing clinicians with engineers?" They said, "Isn't everyone doing that?" And we said, "No, no one's doing that." So it's very unusual to have what we have here. This museum is unusual doing what they do. We're going to wrap up with one short video from John Vozenilek, who's the director of JUMP, the medical director of JUMP simulation. This isn't the JUMP simulation show. It just happens to knit it together. He's going to talk on video about, which we recorded. We're not going to have a conversation with him, but kind of from the perspective of a leader of this kind of innovation, but as a patient's parent.
An encounter today, and this is not, regrettably, this isn't going to be the thing that cured cancer, okay? But I had an encounter today in a physician's office, and the physician was trying to convey information to myself and my daughter about their medical condition. And regrettably, we had a lot of clarifying questions, and I know what I'm talking about, okay? I was really struggling to interpret what the physician was trying to convey to myself and my daughter to really understand what questions to ask, what the future held for my daughter, and all of the information that I needed. Frankly, I think the entire encounter would have been far facilitated if we could look at a model, like a physical model, perhaps something that was existing in augmented reality, and would discuss the issue together to know that indeed the kidney is a little bit smaller, and we're wondering why, and we're wondering in relationship to this other kidney that is the right size. Like, why can't we have this conversation in a new way, facilitated by technology? And if we did that, then does the doctor have to be physically present, or could the doctor be elsewhere? How do we do this at scale? How do we convey information at scale? How do we change the way patients understand their own disease so they can make best decisions for themselves? So much of the time, we're looking at the doctor has to be present, and it's only in the doctor's way that we come to understand. But clearly, that's not quite working. So I'd like to change that. There's no doubt that because, think about this. So, pictures. So I'm of the generation where I still have stacks of physical photographs, okay? And now I have to figure out how to digitize them because I'd like to carry them on forever. Well, we're in that digital age. And the image quality and the density of information within each image is so much greater that now we can actually project images like that in three-dimensional space on either in head-mounted display or in augmented reality. And we're using them for all kinds of interesting things like games and things that are entertaining. But what if we use them for serious conditions? What if we actually could take that idea of digital transformed images and be able to explain disease to patients and have them make good decisions about whether a surgery is indicated or whether it really fits their expectation of the quality of their life. I mean, there are so many really interesting applications for highly mobile, highly distensible technology like this that we actually don't even know where we're going yet. And frankly, again, does it all have to happen with the interaction between that physician in person with that individual, or can we take that to scale as well? So the 3D image, as a printed image, you have a more full understanding of the structure. And what is the difference between reading words on a page and describing what an orange is with its skin and the structures within, and actually being able to see it? It's radically different experience, right? So here we are transforming understanding through those types of 3D imagery.
And at that, I think we'll wrap up the panel. I would just like to say that listening to you guys, and I know all of you guys, it's a pleasure to hear you talk about your fields and the things that you see in the future developing in medicine. I really do hear a localization theme. I hear localizing care to the patient, decision-making by the patients, localizing precision medicine anatomically, genetically, therapeutically, and figuring out more effective care that's more available and less detrimental to the patients. And it's fun that it's happening here in Peoria. And I would also like to thank the museum. John Morris, you're a visionary, and bringing us here to have this conversation. The fact that you guys are packed the audience, thank you for coming. This is a conversation that's of interest. Keep having these conversations, and congratulations to the museum for understanding that there's a thirst for new information and to share what we're doing in Peoria. So thank you for your vision and for sharing it with all of us, and thank you to John.
Ladies and gentlemen, did live up to what I said it would be. World class. How about one more round of applause for our position? I want to give a particular shout out to both Dr. Rick Pearl, who you might have noticed was on the panel tonight. Outstanding job, Dr. Pearl. And Dr. Jim McGee, who had to leave a little bit early. Probably the first two calls along with Dr. Campbell, probably the third, when I became the president of the museum, they said, do an exhibition on medical inventions. And the community will come around and say, how many of you have seen the exhibition on medical inventions? Outstanding. Well, take time to go through. Our curator, Bill Conger, and our whole team have worked hard to put that together. I want to conclude tonight by giving our panelists a small, humble gift from the museum. It's a Future of Medicine coffee mug with the logo of the Peoria Riverfront Museum, which when you drink from it will remind you we stand firmly behind the outstanding work you're doing here in our medical community, from UnityPoint to OSF, jump trading to our medical school, and I cannot be more proud than to have had our trustee of this museum, Dr. Sarah Zallek, sitting right here in front of her beloved mother, Sylvia Knapp, who I think is the most important visitor tonight, Sarah. So God bless the medical community in Peoria, Illinois. Thank you all for coming, and Renee's going to finish up with one little announcement.
I just wanted to say again, thank you all for coming, and we'd like to continue the conversation. So we have some decaf coffee and some water in our lobby and just a few light treats. So please, after you exit the Giant Screen Theater, head into our grand lobby here at the museum, and you can chat with our superb panelists today. But thank you one more time to all of our doctors here for sharing their knowledge with us, and thank you for coming. We hope to see you again soon here at the Peoria Riverfront Museum.